It is 12:02. Dr. Payne, Dr. Lou is here. Luigi Nally is your guy for the next hour. 416-870-6400 star 640 on cell. We're going to get to basically a breakdown of how things happen from the time I walk through the door and start feeling better with you. We'll get to that, kind of a step-by-step roadmap, because people always ask, how does this whole process work when I walk into one of your clinics? So we'll get to that first. So we always have a bit of a week that was.
Yeah, for sure. I think the biggest thing is that I do want to kind of go through a step-by-step because we're having a lot of people coming in and they just want to understand the process. Yep. And maybe it's more of my job to make that clear to the listeners that we have. In terms of the week that was, we've seen, obviously, as we always do, a ton of cases. Some highlights that I like to discuss with people are things that I think are more common than not. One interesting case was, and this is probably something that a lot of our listeners have either gone through themselves or know someone that's gone through something similar. A patient with left foot pain, worse in the morning. As he gets going through his day, tends to get better. If he sits for a long period of time, then gets up, starts to get worse, et cetera, et cetera. As I'm hearing this right off the bat, I'm starting to think plantar fasciitis. Just it's pretty classic presentation. However, the interesting part about this case, and what's very common, is that when people present to their family doctor or a walk-in clinic and they complain of this, usually they'll be sent for an X-ray. And the X-ray will oftentimes reveal what's called the heel spur. So where the plantar fascia is a piece of tissue just at the bottom of your foot, and it attaches at the base of the calcaneus and goes towards the front of the feet. Anytime you have an insertion point of a muscle or a tendon, over time, if those muscles or tendons are tight, they pull on the bone. What happens is the bone starts to spur a little. So you'll actually see a little bit of a spur on an X-ray. And oftentimes, this is very common. A lot of people have it. And the problem is that once that X-ray is taken and they have foot pain, the physician or someone will, or whomever the treating professional is, will say, yeah, you have heel spurs and that's the cause of your pain. When really it's not the cause of your pain. What the cause of your pain is the plantar fasciitis. It's the tight plantar fascia that over time, over your life, has caused that heel spur to form, but not necessarily the pain generating structure in this case. So this person was recommended with a heel spur. You can make specific orthotics where you kind of have a donut in the base of the calcaneus so that it never has to have pressure on it. And sometimes if the pain is due to the heel spur, that's great. It's awesome. So it was sent to me by his family doctor to get those types of orthotics with the donut in it. And as soon as I was able to look at him, I just basically told him, you don't need this because the pain is not being caused where the heel spur is. It's higher up towards the actual plantar fascia. Right. So in the absence of treating that, you're not actually going to get better. So I just thought it was an interesting case to bring up for this week because it is, number one, something that I see a lot of. I do see that kind of misdiagnosis of foot pain and an X-ray always being suggestive of a heel spur when it may not necessarily be. The other thing that I do often see with relation to foot pain is that anytime someone says, I have foot pain, it seems to be the default diagnosis. It's plantar fasciitis. And a lot of the times it is, but it's not always plantar fasciitis. And so, there's specific physical tests that need to be done, and there's specific signs and symptoms that tip someone off to believe it's plantar fasciitis, and just saying foot pain is not enough. The big thing here is, like I always say, if you've got the wrong diagnosis, you're going to have the wrong treatment, which means you're not going to get better. And so that's what I find a lot of, is that people are told they have plantar fasciitis. They do whatever the treatment recommendation is for the plantar fasciitis, but their problem's not getting better because their problem's not actually plantar fasciitis. It might be some other type of foot pathology.
It's like sciatica. Everyone's got sciatica.
Exactly. Right? It's just, it's kind of a very good clinical
or carpal tunnel.
Carpal tunnel,
right?
yeah. And we've
generalizations.
Gone through this a lot, but those generalizations, and again, because of a lot of healthcare is pretty backlogged in Ontario, as we all know. And the reason, when we see something, we default to what's most common. So hand numbness, carpal tunnel, leg pain, sciatica, foot pain, plantar fasciitis. There's lots of things that cause leg pain. There's lots of things that cause foot pain, lots of things that can cause hand numbness and tingling. And you need a place where they're going to actually spend the time with you to get to the bottom of those things.
With actual plantar fasciitis, if that is the correct diagnosis, what's the treatment for that?
The treatment with plantar fasciitis, it really depends on, first off, how long it's been going on, right? Because that will make a big change to the type of treatment. The next thing that really matters is the actual morphology, the shape of that person's foot. So let's take the example of, say, someone with a high arch. And what happens with the plantar, with your foot, is every time you take a step and you have a high arch, there's a springing that happens in your foot, right? And that happens with every foot. And so that's what will oftentimes aggravate the plantar fascia, is that constant springing. So in someone like that, we would want to minimize that. And you could do that either through having the person wear shoes a lot of the times during the day when they're walking, even if they're at home, so that it has good support, so that it minimizes that springing. Sometimes it could just be very intensive release therapy, massage of that plantar fascia to just break up any scar tissue or adhesions that have formed. Sometimes it goes so chronic that maybe something like shockwave therapy tends to be very good. So it really depends on exactly the case of the plantar fasciitis. And that's, again, John, I always say that you can't just pick a pathology and say that the treatment for that pathology is always this. It has to be individualized.
Phone lines are wide open, 416-870-6400, star 640 on cell. And, we always mention as we get to the show, free consultations. They want to drop by and see. That's where it all starts.
For sure, yeah. So that goes back to the process. Step one with anything is if you call the 1-855-55-Dr. Lou number, you're going to either be able to get transferred directly to my main clinic, which is Humber Family Rehabilitation and Wellness, or you can leave a message by pressing 2 for me, and I will return that message. So you'll leave a message. It'll ask for some details about why you're calling, and then I will personally call you back, and we can have a discussion. Now, that free consultation, we can do it in office. We can do it over the phone. The point of the consultation is just for me, essentially, to do what it suggests, to consult with you. Let's hear what the issue is. Before we take any steps towards any treatment, et cetera, let's see if it's even something that I can, help you with. Maybe it's not, and I have to point you to another person in my network of professionals that I think may be a better fit with you. I did this with a gentleman yesterday who came in, free consultation. He wanted to come into the office. He told me a little bit about his complaint. I think my biggest strength is that I know my limitations as a professional. And as soon as I saw this gentleman, I said, I'm going to set you up with the right person. I referred him to Dr. David Greif, who's a colleague of mine. And I said, this is the person you got to see, because this is the person who, if anybody's going to help you, it's going to be this person. And so that's the way it starts.
Hey, Corey, we're going to squeeze you in here before a break. What's going on with you?
Oh, good afternoon, doctor. How are you?
Good. Yourself?
I'm fine, thank you. I've had an issue going on for a couple of years now with some little white cysts, like bumps on top of my earlobe.
Okay.
On my left ear. And I went in to see the doctor. He told me they weren't cancerous or anything. Mm-hmm. He tried to freeze them off with, nitroglycerin or something.
Right.
And he said I had to keep coming in every, 2 weeks.
Okay.
To, get it rectified. But I ended up just purchasing, the Dr. Scholl's wart remover kit, which have that built in. Mm-hmm. And I used it on a regular basis, like every 4 days, and I have had no results. I went and got some cream, actually, because I had a family member mention that they had it on their ears, and they used this cream called, what was it? Effudex.
Okay.
I don't know if you're familiar with it, but I guess it kills any kind of mutant cells. So I guess it's a precancerous treatment.
Yeah,
I've been applying that since December 22nd, and I still have had no results. I got a follow-up coming up this week to the doctor, but just wonder if you had any advice.
Yeah, I would definitely say the biggest thing, and again, I don't deal with cysts and things like that per se in terms of removing them, but, using something like the Dr. Scholl's wart removal is going to be effective if it's a wart, and if it's not a wart, then it's not going to do anything for the cyst. And so I think this goes back to what I was just talking about with proper diagnosis equals proper treatment equals resolution of whatever the issue is. Absolutely. And I think it is worthwhile, and I think you're doing the right thing by following up with your doctor and actually figuring out what's forming the cyst. Once you can understand exactly what it's from, then you could treat it accordingly. Because it sounds like the interventions that you've tried to use on your own, it's probably not targeting the right thing just because that's not the right diagnosis. So I definitely think keep following up with your family doctor and try to figure out
dermatologist
exactly.
Maybe.
Or dermatologist, yeah.
Or a dermatologist, because his next step was to surgery, right? Scalpel. And I'm like, well, let's try some other things.
Yeah, I mean, and sometimes we've talked about this a lot with surgery, and there is a growing I think most of the population right now, John, is moving towards, I see a lot of people who say, I don't want medication, I don't want surgery. But we do need to realize that sometimes it does play a role, right? And sometimes, as we've talked with surgeons on this show before, it may not necessarily always have to be the very first step, but it needs to be something considered in the line of treatment if other things aren't working.
416-870-6400. Your phone calls coming up, star 640 on your cell. And have this number on your phone anytime to get a hold of Dr. Lou. The email is info@paincarecanada.com and 1-855-55-Dr. Lou. Quite simple. Dr. Payne Show continues. Talk Radio AM 640. 416-870-6400, star 640 on cell. That is the number. 12:15 on your Saturday afternoon. Esmina, love talking to you. How are you?
I'm good. How are you? Good afternoon,
Good.
Dr. Lou. Thank you so much for your advice last Saturday regarding my son's Bell's palsy. We feel much better as parents this week.
Awesome. That's great to hear.
What transpired after the phone call? What'd you do?
So basically, like the way Dr. Lou was assured us so well that, he had seen that example in his life and it was time that would help it. And we tried to monitor him every day, seeing his face. And trust me, his eyebrows are going up. His smile is becoming much better. And actually today when my husband woke up and he says, I think, Esmina, it's 80% quite well, and we feel very grateful to Dr. Lou for that advice.
No problem. Esmina,
we still have your clinic's phone number. If we need any help in the 20% that we don't see any improvement in, we'll definitely call in. We actually did call in and talk to Michael, and we will definitely keep that number handy. Thank you so much.
No problem.
Thanks.
Yeah, Esmina, you sound like a great mom.
The biggest thing with the Bell's palsy that I do find is getting the people to actively try and think of doing what they need to do. And that's, the biggest thing in healthcare often is the education and empowerment, right? Which is exactly what we're trying to do with this show. Someone as simple as that. And I get that a lot. A lot of the times that's the consultation. Somebody calls me. I'm able to just tell them one quick thing. They do that before anything comes in. And what have you really lost? Nothing. You've gained so much by just having a little bit of education. That education empowers you to make a change either for yourself or someone like you love, like Esmina's son here, and people get better. And then in the absence of not getting better, there's other steps that we take. That's when we move to the assessment, potentially treatment, et cetera, et cetera.
416-870-6400, star 640 on your cell. Dave, how are you?
Good, thanks.
Good, pal. What's your concern?
Well, it started last summer, and from driving, I drive my boy a lot for baseball and these long journeys, and I started to get a lot of pain in my right leg, the one that uses the gas, down just above my ankle on the outside part and just above my knee, like the lower thigh area at the back. Mm-hmm. And now just sometimes sitting down too long, the pain comes. If I'm driving in my car now for 10 minutes, I'm driving right now, but not hurting at the moment. But it gets to the point where it's almost unbearable. I got to pull over, get out, and get my leg in.
So this is, Dave, pain at the back of the leg, just to confirm? Okay, and what does the pain feel like? Can you describe the character of the pain?
I don't know, I guess sharp.
Sharp. Okay, sharp, burning, any numbness, tingling, anything like that?
It comes and goes. Like it'll go away for a minute or two, then it comes back.
Mm-hmm. Okay. Yeah, a lot of the times what can happen, and again, I can't be 100% sure, but what it sounds like, where I've even myself experienced this sometimes, is with driving long periods of time. If you understand the anatomy of specifically the sciatic nerve and the way it has to run, anytime you're in a flex position at your hips, that's going to put extra tension on the sciatic nerve, which is what happens when you're sitting, bending, etc. Your hips are flexing. And then not to mention you're driving, so you're bringing your foot up, down, up, down. As your toes point upwards, that tends to put more tension on the sciatic nerve. So a lot of the times if there's an underlying issue that could potentially cause sciatica, like a disc bulge or something like that, that may not be necessarily symptomatic when you're moving around doing things, with prolonged sitting, it can have this type of an effect. And obviously, he's saying his right ankle, right knee, which is the knee, or the leg that would be extended to be on the gas and the brake. And it's not necessarily the left one, because the left one, he's probably able to bend the knee. And in doing so, you shorten the tension on the sciatic nerve a little bit. So, Dave, it does sound like it could be tension on the sciatic nerve. The next question becomes, again, that's just a clinical sign and a symptom. What exactly is causing that tension on that nerve on that side, which could be something like tight muscles from driving a lot. It could be something like a disc bulge that's only symptomatic during that time, but it's definitely something that sounds like it needs to get taken a closer look at for sure.
Okay.
Okay, Dave?
Thank you.
No problem.
Yeah, I bet she doesn't have a clutch in his car. That's for sure.
Yeah,
right?
exactly.
You know
Right.
what I'm talking
Or he'd have
about?
pain on both sides.
You got it. Hey, Mohammed, good afternoon. How are you?
Hi, good afternoon. How are you doing?
Good. What's your concern, pal?
My concern is my grandson is 2 years old. This kid is very active. He does everything, and he understands everything you speak when you speak with him. But he doesn't actually say. He doesn't say anything, any word.
Okay.
If I ask him to say A, B, or whatever, he doesn't say it. And normally we have 7 grandkids, and they all do it. They all spoke very well, during this age.
Mm-hmm. Okay. And what's exactly your question for me then,
My
Mohammed?
question is, do you think there's anything we can do, or is that a normal thing? Some kids develop faster, or they will speak.
Has he been checked yet? But like, have you mentioned this to the pediatrician, et cetera, et cetera?
Well, I'm not too sure if my daughter spoke with the pediatrician as yet.
Okay, yeah, I mean, it could be a multitude of different things. Again, this is not exactly my area of expertise, but what I can tell you for sure is that all kids do tend to develop differently. Okay. But, it could be something more than just delayed development like that. It could be, something else. So definitely looking at it from the behavior sciences side is an important aspect. And I would say the first thing to do is have your daughter book an appointment with the pediatrician and bring this concern to their attention. And then that way they can start the right process of maybe a speech pathologist gets involved, or maybe there's simple, recommendations that the pediatrician can make. But absolutely, that's something I think that needs to be communicated with the pediatrician.
Mohammed, appreciate the call. Plus, boys, I think generally start speaking later than girls. Right?
They can for sure. But, again, this is the point of a consultation, right?
You bet.
Nothing I'm going to help, but, good advice on what to do next.
416-870-6400, star 640 on cell. You go to info@paincarecanada.com. You want to drop Dr. Lou an email or call the clinic anytime. Set up that free consultation, 1-855-55 Dr. Lou. It's the Dr. Payne Show, Talk Radio, AM 640. Hey, your phone calls, bring them on. We're here till 1 o'clock this afternoon, 416-870-6400, star 640 on cell. Diego, good afternoon.
Hi, good afternoon, guys. How you doing?
Good. What's going on with you?
I have a question to the doctor. For the last past, I would say 2 or 3 months, my right foot on the big toe, just underneath the big toe, I'm feeling like a burning sensation from time to time. I do a lot of running at the treadmill and regular at the gym. I work out like 4 to 5 days a week. I stretch myself after, do my things. But as I said before, for the last past few months, I can't have that burning sensation under my big toe. I don't know what could cause that problem.
Yeah, okay. I mean, again, there's a lot of things that can cause that type of problem, but again, with the detective work that we try to do in healthcare, we start listening to the things that people are saying, understanding anatomy. So going back to the character of his pain, burning sensation, we've talked about this before. Yeah. Burning sensation already tips me off towards a neurological issue. Understanding the anatomy, the big toe is a perfect place. L5 dermatome is in that area. So, you would think something along the sciatic nerve, right? So it could be, Diego, something like from the running, maybe certain muscles where that sciatic nerve has to pass through are just getting tight. And in the absence of doing any therapy or getting those muscles released, it's going to keep putting pressure on that nerve. Anytime there's an issue on the nerve, pressure being put on the nerve, it does tend to be felt peripherally, in this case. So you could have something like in your buttock at the piriformis, but you don't feel it except
not at source.
Yeah, exactly. Right. Or it could be behind the knee.
I should mention this, but from time to time I feel numbness, and I have a problem for the last past, I would say, 15 or more years. I have 2 herniated discs.
Yeah.
And I don't know if that could be...
Yeah, that's exactly. And again, this is the whole component of a proper assessment, the dialogue, right, where between patient and practitioner, now there's a previous history of disc herniations. The numbness sensation is absolutely a neurological issue. So yeah, Diego, it sounds like it's probably something related to the back. and it's just causing that pain at the bottom of the foot, maybe the way you're running. This is where what we do with these types of patients and people like you, the functional assessment, where we actually will get you on a treadmill, look at how you run to understand where there might be pressure and areas of concern going forward. So yeah, Diego, give us a call. We can definitely help set something up and see if we can help you and figure out how to keep that issue at bay.
Yeah, Diego, 1-855-55 Dr. Lou. So you get them on there, you'll measure their gait, you'll look at the way they run, just get it in real time, right?
Yeah, exactly. It's just more using my knowledge to actually assess someone properly. So as we started the show by saying people come in, initial consultation, similar to what we've done here. A lot of the times it's, like the example with the cysts on the ear. That's not necessarily something I'm going to help with. But the one thing I think that most people find challenging is a lot of times they don't know the right things to say to their doctors. And so a lot of the times what I've done with people when I'm talking with them is just give them simple advice on here's what you should ask your doctor, or here are some things that you may want to consider and some other people you may want to see. So that's just as important. If it's something that falls within the neuromusculoskeletal realm, which means anything to do with nerves, the muscles, the joints, bones,
discs.
Yeah, that's going to be really my area of expertise, where that's the things that I'm dealing with. That's when we move to an assessment. Now, an assessment is properly going through a full history, a full physical exam, and if any special tests are required, those tests are ordered in order to understand, okay, what's going on. In that physical assessment, it could be things like neurological testing, if it's a neurological issue, orthopedic testing, functional testing, similar to what we were just speaking of, where someone in this type of scenario, we're saying, okay, it's hurting while you're running. Let's get you on the treadmill. Let's see you run. Let's see what you're doing. And then I start looking at understanding anatomy, where certain pressures could be happening, and starting to get, okay, here's maybe why this is happening. And then plan of management falls after the assessment. Plan of management, again, may be something that I think that my team could deal with specifically at my clinic or my providers' clinics. And that's going to be mainly focused around the rehabilitation aspect of things. Or if it's something that I think, no, maybe this person needs a surgical consult, then I'll send them off to surgeon. So again, the treatment really depends on the diagnosis. Oftentimes, the things that we can specifically treat, we like to say that we try to focus on treatments that are drug-free and non-surgical. That's really our expertise in our clinics. And again, I think that's what a lot of the population is looking for, to avoid heavy dosages of pain medication,
less invasive stuff,
and or surgery, and again, that doesn't mean that we never refer people for those things, but we do try to achieve an effect and get people better with a drug-free, non-surgical approach. If that doesn't work, then absolutely we make referrals to the appropriate people for those interventions when they're required.
416-870-6400 *640 on cell. You got some time, you got some questions, some physical concerns, always wanted to ask a doctor. Now's the time to bring it on. We're listening and waiting for your calls. Lots more of the Dr. Payne Show straight ahead. Talk Radio, AM 640. 416-870-6400 *640 on cell. Your phone calls can take them right till 1 o'clock here. We'd love to hear from you. info@paincarecanada.com. Indeed, that is the email. And that free assessment, get it happening. There's the first step, 1-855-55 Dr. Lou. So I guess an obvious question, but I guess when someone comes to see you, if they have and do bring as much background, as much information as they have from other doctors or tests or other things they have, they're armed with, right? Always helps.
A lot of the times what I'm actually getting in terms of the assessment is I like to say that I'm also offering second opinions is a big part of what I'm doing for people. And it is always easier when you come with the things that you've already had done to you, because a lot of people, a lot of doctors such as myself, we tend to think the same. We hear an issue, it's like, well, you could use an MRI. And then it's much harder with a patient who says, oh, I do have an MRI, but it's at home, or I didn't get it. And it's like, okay, well, that's going to it's again, going back to the onion analogy, and we got to peel layers away. So actually, it was funny. I had a patient yesterday, 31-year-old female, and she brought a binder of her history that was nicely organized. It was in perfect order, because this was an issue that she had been suffering from since her teens. And so I was very easily able to go through that and really start to say, okay, yeah, that's good. That was good plan of management. That was a good next test, et cetera, et cetera. And it made it so easy, and it made it so much easier for me to give her the proper advice. And in fact, I do this with my own family, where anytime something is done, I always ask for the actual record for my own history to keep in a log. Like, I'll do this for my mom. I've asked my brothers and sisters to do this. Keep your own medical record. Create your own medical file. So that way, God forbid, or you have to, ambulance comes to your house, doesn't know anything about you. It's very easy to say, here's everything. And then that can give a quick sense to people as to, okay, here's what I can do, what I shouldn't do. Same thing if you're presented to the emergency room. It just provides an easier way for the professional, that's the treating professional, to get the relevant information that they may very well need. That could be a matter of life and death.
You bet. 416-870-6400 star 640 on cell. We got open lines. You want to give us a call? It's, you can't judge out there today because it's pretty mild, but it will get uglier before it gets better. Snow, ice, all that stuff comes around, and the slip and fall cases coming through your door must be monumental this time of year.
Slips and falls and car accidents, absolutely. Right. We definitely tend to see a big increase of those types of accidents during this time of the year, obviously because of the weather. And, as we've spoken about before, those are things that need to be dealt with properly. They need to be dealt with the right way. One of the problems that I see, and I know when we've had Savan on the show, he's spoken about this too. Oftentimes people, as an example with the car accident, are in a car accident, and they're speaking to their adjuster from their insurance company, and they're recommended to go to what they call their preferred provider network. And I'm not saying all of these clinics are not good, and I'm not saying that they're not good anyways, but the one thing that I would caution our listeners is that when you get into a car accident and now there's another person responsible for paying for your treatment,
right.
When they create preferred provider networks, a lot of the times what happens is those preferred provider networks are solely reliant on new patients through that network. And that means they might be biased to that insurance side, right? And so when it goes into dispute and there's a litigation factor, you may not have the best people on your side. And so, I'm not saying that those clinics are bad. I am not trying to make that comment. All I always try to tell everybody is do your research. Understand where the patient base is coming from. I always caution people with any clinic, go to clinics where there's a diverse patient base. People are coming in through provider networks, through referral networks, through word of mouth, because that means no one component of the business aspect is solely reliant on one referral source, because then they might tend to be biased towards that one referral source.
You mentioned Savan from the Insurance and Injury Law Show here on 640. He often says the same things about insurance companies referring you to doctors.
Yep.
You might get a great diagnosis. It might be counter to what your own doctor and practitioner has been saying throughout your coping with your injury or your slip and fall, but they are getting paid by the insurance company.
Well, I actually have a division of our clinic where we do independent medical assessments for the insurance side and also for the plaintiff side, the legal side. And again, I think the biggest thing here, these examinations are called independent medical evaluations. And what they're essentially trying to do is get an independent, objective measure of the person. And anytime there's, again, referral only coming from one source, those practitioners may tend to be biased, and really you need to be independent and you need to give objective advice. And if that objective advice goes against the referral source, then so be it. That's just the reality of good clinical practice.
416-870-6400 star 640 on cell. We'll get to some of your calls here in just a moment as we get them lined up. We got open lines. You want to give us a call? We'd love to hear from you. And in fact, we got Bob on the line. Hey, Bob.
Hi.
How are you?
I'm great.
Okay, what's your concern?
I'm great. My friend isn't great.
All right.
He was working on a weekend at home, and he was reaching up something. He was on a ladder, and he pulled something in his knee.
Okay.
So he was off work for a few days, and then because he wanted to go to the doctor. He said, "Mom, my leg's really," he called in sick, and he said, "I hurt myself on the weekend. My knee hurt," So he went to the doctor. The doctor, they did an X-ray or something, and they said, "Gee, I don't see anything. Just take it easy and here, take these, and you should, if it hurts a lot, take these, and you'll be okay."
Right.
So then he started walking around, and then he started not being able to kneel down and stuff like that. He started having a lot of problems with his knee.
Okay.
So then he sent him to another doctor. And the other doctor looked at him and said, "Gee, I don't see anything," and they had already had an X-ray done.
Mm-hmm.
And so then the guy's been prescribing him painkillers. So then he was working about a week ago, and all of a sudden he's driving along and he pulled the car over and he said, "Oh my God, my head is aching so bad. I have to go home. I can't stand it."
Mm-hmm.
And he slept for like 12 hours, and then he was okay the next day. But it's like he needs to get and figure out what's wrong with his knee.
Yep. Well. Okay, so let me start by first saying that this is a big problem that we face in healthcare, is that someone has a physical issue, and that type of presentation. So if that came to my office, just Bob, going based on what you've said about your friend, on the ladder, reaching for something, pulls his knee. He didn't fall off the ladder, right?
No, nothing like that.
Yeah, so there's an absence of trauma. Right? Yeah, My biggest indication for sending for an X-ray in a scenario like that is I'm thinking trauma, maybe there's a fracture. There's an absence of trauma here. There's no reason to think that anything broke by reaching. What there is more of a likelihood is that it's soft tissue damage. Maybe in reaching, he strained a tendon, strained a ligament, whatever it may be.
Yeah. When he was reaching, he told me, he stretched out really far, and then he came back, and he sort of came down on the wrong angle,
Right. And so that, to me, suggests more like an ultrasound, right, to look at the soft tissues. It's a simple initial intervention for imaging, and it also minimizes radiation being exposed. So there's problem number one. Problem number two is I hate when I hear that someone went somewhere and they were given a pill and said, yeah, just take it easy. That's what creates chronic issues and creates issues that tend to come back. I try to really, really educate on this fact. If it's a physical issue, you need a professional who's a physician or a doctor who deals in the physical realm so that they can do physical intervention. And that means if it's a physical problem and needs physical intervention, that's where seeing a chiropractor, a physiotherapist, a massage therapist, any healthcare professional who deals more in the physical realm is probably going to be better for this than just someone who says, yeah, here, take this pill. Because you know what? That's the reason why we have an opiate epidemic or a contributing factor at the very least. It's this type of outlook where it's just like pain, take a pain medication. Well, there needs to be some type of intervention. And I would hope that most, primary contact professionals out there, when they are hearing that it's a physical problem, that they're also recommending a physical intervention. And that's my hope. And I'm not, I can't comment for sure because I don't know the case fully, Bob, but I would hope that is something that's being done. And, for your friend, the biggest advice at this point is get him to see the right people. Give us a call at the 1-855-55 number. This is a consultation. This is the type of person that I would move towards an assessment, because I would say, yeah, this is absolutely something we specialize in.
I've listened to your show a lot over the last several weeks.
Okay, thank you.
I've heard all the stuff, and I think it's really great what you're doing.
Thank you.
It's really something that an alternative that we really need in this.
And you know what?
I hand them the pill prescription thing that's going on.
And you know what, Bob? I think that's a great point. And a term that I like better than alternative, because alternative just by its very nature may suggest like a competition. I like the term integrative. That's what we strive for, is integrative therapy, because we're not opposed to medication. We're not opposed to surgery. We're not opposed to those things, but we are opposed to it not all being put together.
You bet.
Right? And that's integrative healthcare. And that's where our healthcare system is moving, is integration. And we want to be at the forefront of integration for pain management.
Your phone calls, hang on. We're coming right back. 416-870-6400 star 640 on cell. It's a Dr. Payne Show on Talk Radio, AM 640. Getting to your calls, answering the questions. Dr. Lou's here till 1 o'clock in the Dr. Payne Show. Rose, thanks for hanging through the break. How are you? Good.
Thank you. How are you?
Good. What's your concern?
Yeah. So in the beginning of the program, you were talking about plantar fasciitis.
Yep.
And I just wanted to say that I actually went through that, waking up every morning in excruciating pain on my feet, not being able to stand on my feet.
Yep.
So I went in to see my physiotherapist, and they had me go through 12 sessions of shock therapy.
Mm-hmm.
I went through the whole 12 sessions, and it actually cured my problem.
Awesome.
Yes, it was fantastic, and thank you for mentioning that and for your program. And they also mentioned that the reason why this was happening to me is because us women, we have a tendency to want to wear our flip-flops every summer.
Yep,
and
for sure.
Unfortunately, there's not enough support, right?
No, there's no. It's the worst thing. And again, if you're someone with proper arches or high arches and you're wearing flip-flops which have no support. Now, the one thing that I do want to caution on the shockwave therapy, shockwave tends to be a very expensive machine, and oftentimes there's an upcharge at a lot of clinics for the shockwave therapy. And I'm not suggesting that that's the case at your clinic, but I would always try to do shockwave therapy based on the research tends to be much better for the chronic issues of plantar fasciitis, because there's many people that we see with plantar fasciitis that we can get better with just our regular treatments and not necessarily have to jump to an intervention that has a big upcharge to it. So I'm glad that you're better, and that's all that matters. But specifically more for our listeners in general, don't just, say if someone's saying, yep, shockwave, and it's an extra $50 charge every time, and you need 12 sessions or it won't help. Like, that's when it starts to become a little, and again, sometimes it may be needed. I'm not suggesting that that's not the case or that that's the case all the time, but I just did want to put a little asterisk next to that shockwave therapy for sure. But I'm glad that it helped.
Yeah, that's good to know. And also, so now before I wear those flip-flops, I always think twice, and I make sure I have a little bit of an arch in them now.
For sure.
Like maybe a fit flop or something like that,
Yep, for sure.
Makes a world of difference, along with, like what you said, the orthotics as well, right?
Well, and that's a big thing, Rose. After you're done treatment, when people get better, the next thing, what do I always say? The education empowerment. Now that you understand, it helps you to prevent issues because you now understand. And also now you'll also realize if it does start to come back a little bit, you're going to know what to do right away. And that's a big component of therapy. Any place where you're getting therapy and there's no education, no empowerment, I'm so happy to hear that you're going somewhere where they explain the flip-flop thing to you, because when those things are not explained, it eliminates the potential for the person to make their own change in the future.
It's like a pair of Chuck Taylors. They look great, but there's not a lot to them.
Not a lot of support.
Not a lot of support there. I got Angus in Oakville. Hi, Angus.
Hey, how are you?
Good. What's going on with you?
Yes, I got a question to ask doctor. 3 years ago, my wife she had surgery done to remove part of her colon, and they attach the colon together, right?
Yep.
And last week, whatever she ate, she kind of threw up everything, right?
Okay.
Everything, and I took her to see a doctor to the hospital, and they do an ultrasound. I mean, they do a CAT scan and X-ray. They found something in her colon got tangled together, right?
Mm-hmm.
So then the specialist said she got two options: one, to wait to pump everything out so the colon can untangle itself,
right? Or
they had to do surgery to untangle themselves, right?
Mm-hmm.
But luckily, we take option number one, to wait, and the colon did untangle itself.
So
right?
this is more like, I guess you're talking about an obstruction, a small bowel obstruction. Yeah.
Correct.
Yeah. And that's often the procedure that the professionals will recommend. If it's not life threatening, like immediately in that time, they'll say, let's give it a few days of medications, wait it out. Or if it doesn't resolve, my dad actually had a similar thing to you, Angus, or to your wife, where same thing, a bowel issue, it was obstructed, and the recommendation from the general surgeon was surgery, but let's wait first. Let's do some interventions that are not as invasive, and it luckily got better on its own. But it sounds like that's the proper procedure.
But my question is, in the future, right, to avoid this situation, what should do from now on?
Did they mention why there was an obstruction?
No, they didn't say nothing.
Okay. Has your wife ever had any surgeries, like an appendix removed, or pregnancy, anything like that?
No, nothing at all.
Yeah, so a lot of the times it's very, very hard to say. One of the common things with small bowel obstructions is previous surgeries. So any adhesions tend to, over time, just strangulate that point. So it's very common in people that have had like an appendix removed or didn't deliver a baby naturally and actually had their stomach cut, and then there's some type of an incision. So sometimes it could be that. Sometimes it could just be something that's introduced to the body. It's very hard to say. So I think the only way I can recommend to maybe prevent it is maybe try to understand what could have caused the first one, and in the absence of that, it sometimes is just, I guess, a case of bad luck.
Okay. All right. Thank you very much.
No problem. Take care.
Thanks, Angus. We'll take a short one. We got more phone calls coming up, but we have room. 416-870-6400 star 640 on cell. Again, those free consultations, you can email Dr. Lou, info@paincarecanada.com, info@paincarecanada.com, and the clinic, of course, 1-855 Dr. Lou, Dr. Payne's Show, Talk Radio, AM 640. 12:51, still a few minutes here to get some calls in. 416-870-6400 star 640 on your cell. Hi, Joan.
Hi.
How are you? What's going on with you?
I'm pretty good. How are you?
Fine. What's your concern? Dr. Lou's here.
Well, I've got a nephew. He's 14 now. When he was born with severe clubfoot. The fact that the foot was turned to going to the other foot, and it was turned on the side of his foot. So, he was casted from birth until about 2.
Yep.
And then at 2, they did a surgery where they pull the foot down, go flat, and put all the tendons down.
Yep.
Reconnected and what have you. Now, he's 14, and he wears a size 10 on one foot and a size 8 on the other foot.
Okay.
It's very, very difficult for me to buy
shoes.
A size 8 shoe, and
Yep. Yep.
Anyways, now he's complaining of pain in his foot. So I don't know what to do about that, and how do I get a size 8 and a size 10?
Okay, well, this is where things like orthopedic shoes an orthopedic shoe is a specific shoe made for exactly this case. A lot of people, there's often a confusion between orthotics and orthopedic shoes, and a lot of insurance plans have coverage for both an orthotic and an orthopedic shoe, and a lot of times I'll have people come in saying, I want an orthopedic shoe, and it's like, well, you don't need one. This is exactly the case where an orthopedic shoe is exactly what you need, because like the problem you mentioned, it's very hard to go to a store and say I need a 10 and an 8 on
break
this.
up a set.
Yeah, you're not going to do that, right? So this is where going to places that specialize in orthopedic footwear, they can actually make the shoe specific for the exact size and the exact deformity that exists. Have you ever considered that?
Well, I didn't know where to go. And number one, it's the fact is that he's 14. It's a peer pressure. The shoe has to. What does an orthopedic shoe look like?
Well, an orthopedic shoe can be any shoe you want. Like, I know the people that we work with, they will make whatever shoe that the person wants. It's not like 30 years ago where it was that just that
tan
big black
thing
shoe or the tan
grandfather would wear.
No. They can take any type of shoe that the person wants and modify it specifically for that reason. Now, obviously, it's not the same as if you went to Foot Locker or wherever and bought that. There's obviously an extra charge. But as I did say, a lot of insurance coverages include coverage for orthopedic shoes. So it might be something for you to look into if you do have that. Give us a call. I can definitely put you in touch with people that specialize exactly in that type of footwear.
Awesome.
Okay, thanks, Joan.
Awesome. Thank you very much.
No problem.
Appreciate it, Joan. It's 1-855-55-Dr. Lou. And the email, once again, info@paincarecanada.com. Joe, good afternoon.
Hey, good afternoon. How are you?
Good.
Great. I wanted to just share a thought and get some opinions from you folks.
Yep.
I've had a left shoulder issue for about 7-8 months. Have gone to get an MRI, and it didn't show any tears in the rotator. Have been... I guess I've had about 9 shockwave treatments, and what I'm hearing is that there is some micro tears in the not the supraspinatus, but underneath the supraspinatus.
Infraspinatus?
Pardon me?
Infraspinatus?
Yeah.
Okay.
And I'm still continuing getting the tingling in my 3 fingers. So my range of motion is limited. And it's a little frustrating because I'm trying to strengthen it with the elastic, do some exercises and that, but I'm not feeling it, So I'm not sure what I should be doing.
Okay, so have they given you a diagnosis for your shoulder?
Well, all they're telling me is that there's some micro tears, nothing to do with the rotator. It's underneath the rotator, some under the supraspinatus, and that's basically it,
Okay. One of the things, and Joe, I don't know how often you've listened to our program, but we've talked about this a lot. The shoulder is a very, very complicated area because it essentially only attaches to your body kind of at the clavicle, and the rest of the things that hold it to your torso are all muscles. The one thing that changes drastically with everybody is the orientation of the scapula, which is the shoulder blade, on the rib cage. And when that changes, it changes the dynamics of the shoulder. And a lot of shoulder problems that are diagnosed as tears or this or that are nothing more than just bad posture in that shoulder blade, and doing specific exercises to correct the function of the shoulder girdle is what ends up making the world of the difference in those other structures, because now it brings it back to a proper area where there's no extra added pressure on certain anatomical structures.
Right. So I guess my question, and maybe it's not a fair question, I mean, after 9 sessions of shockwave treatment, I should have seen some results, right?
Well, yeah, and here's the thing with, again, where I talk about the upcharge of shockwave and why some clinics may be inclined to push for it. One of the things that, again, when we treat people, we're treating people based on what's called evidence-based care. Evidence-based care means what's the best available literature, scientific literature, what's the clinical experience of the person, and what does the patient want. The big thing here that I want to highlight is the scientific literature. Most of the scientific literature on shockwave therapy in the shoulder actually supports its use for calcific tendinitises. So I'm not sure if that's what you've been told that you have, but in the absence of having that, it's probably not the best intervention for you. This is, Joe, you're the exact example of where I feel a consultation could move to a proper assessment. I'd love to have you in the clinic. We could take a look at it and we can get you the right answers if that's something you're interested in.
Yeah, I'd like to take it to the next step. For sure.
Awesome. Yeah, give us a call, 1-855-55-Dr. Lou. It's DRLOU, and that's for all our listeners. Consultation, again, that's as simple as it is. I'll hear your issue. If it's something that I think we can definitely play a role in getting you better. With this type of case, the other thing I want to highlight is if you're going somewhere and you're getting therapy, and you like the people, but you're not necessarily happy with the type of therapy, I don't take anyone away from any clinics. I'm happy to communicate with the providers that you're using, with the people that you're using, and just make recommendations. Also, if there's providers and there's healthcare professionals out there listening that listen to our program, if you're interested in being part of my provider network and you think you do a good job and your views seem to match my views, give me a call. I'm always looking to add people to grow the team because that's what healthcare is all about, is just having a bigger and bigger team so that we can do a better job for every single person that's living with pain and try to do our best towards getting people pain-free.
Another fantastic hour there, brother. We'll take it for another week. In the meantime, in the downtime for us, the number is 1-855-55-Dr. Lou, DRLOU, and email info@paincarecanada.com. Get that free assessment happening. Get on the road to recovery and being pain-free for sure. The Dr. Pain Show on next weekend once again. Talk Radio AM 640.